Okay,
Can
so
we
good
start?
morning, everyone. Yeah, you want to give a count, Rishi?
Yes, sir. We are live in 5, 4, 3, 2, 1. We are live now.
Yeah, thank you. So, good morning, everyone. Uh, After a long break due to POSICON 2025, we are back for Fellows Teaching module, which happens on every Saturday morning. And to start, I came across a few trauma cases, and my fellows who have joined recently. Uh, they I found that it would be very good for them to start with pediatric trauma. Uh, we have today a nice talk from Dr. Vidyasagar, who's a good friend of mine from Hyderabad. And then Dr. Preksha will present a very atypical pattern of supracondylar fracture, which we have observed in few cases. And we did not find a typical description of that pattern. So at the end, Vidya can tell about it. So Gaurav, uh, and Preksha, all over to you. Kindly introduce Dr. Vidyasagar and moderate this session. Thank you
Right.
very much. Welcome, Vidyasagar.
Thank you. Thank you.
So, Dr. Preksha, would you be introducing Vidyasagar sir?
Yes, sir, sure. So, Dr. Vidyasagar sir is an expert a pediatric orthopedic surgeon from Hyderabad. He has received the prestigious Top Doctors South Award consecutively from 2022 to 24. He practices at multiple centers. His alma mater is from Bangalore. I'm assuming it's Siddhartha College in Tumkur. And so you can take over and present your.
Thank you, Preksha. I'll just share my screen. So, is my screen visible now?
Yes, sir.
So, supracondylar fracture is a very common fracture, and I'm sure everybody is going to deal with these fractures in their day-to-day practice. And coming to anatomy, we all know the humerus proximally it is circular in the middle shaft, and as it goes distally, it becomes triangular, and distally it terminates into most of the cartilaginous structures which are intra-articular, like trochlea, capitulum. So there is a weak link between the proximal distal humerus and this, which is the olecranon fossa. And whenever the child has a fall on outstretched hand, especially when the olecranon of the ulna pushes into that fossa with a hyperextended elbow, that link can get fractured easily. And that's what leads to our supracondylar fracture. And what is also important is when there is a displacement, there is a neurovascular bundle anterior to the proximal fractured fragment, which can get easily tethered, and that can lead to neurovascular complications like deficits, absent pulse. And when you reduce it, sometimes it also remains stuck in the fracture site and can lead to persistent deficits post surgery. So most of us, when we think of supracondylar fracture with pulseless hand, we think that it is because of spasm, but spasm is only in 8% of the cases. There can be other varied different types of injuries like kinking, tethering, intimal tear, thrombosis, and even laceration. So this is important to remember. But what we want to know also, what is the perfusion of the hand? So just because the brachial artery is obstructed doesn't mean there is no perfusion to the hand, because elbow is a joint which has rich collaterals, and this deficit can be even supplied by the rich collateral and can sometimes show as a visible pulse also. So this is most important thing, the perfusion of the hand rather than just the pulses. 50 to 60% of the pediatric elbow fractures would be supracondylar fracture, which is followed by lateral condyle fracture. And Most of the times it is because of the fall on the outstretched hand with elbow extended, but there have been other reports where the child falls on the elbow directly. And coming to classification, Gartland has put up a classification, a very early classification, which is described as flexion, where the distal fragment actually goes into anterior displacement and flexes, and extension type, where the distal fragment goes into extension. And this extension type is again further classified into 1, 2, and 3. 1 is basically minimally displaced or undisplaced fracture. Type 2 is a fracture which posterior cortex is intact, whereas the anterior cortex is broken. So that means if you draw anterior humeral line, it would cut anterior to the capitulum rather than through the middle third of the capitulum, which I'll describe in coming X-rays. And type 3 is a fully displaced supracondylar fracture. Again, Wilkins has added type 2 A and B. A is basically a fracture which is rotationally stable, and B is rotationally unstable fracture. And there is also a multidirectional instability described by Leach et al. And type 1 also has been classified into 1A and 1B. 1A is a regular one fracture. B is one with a medial varus collapse or a medial comminution, which can go for cubitus varus later on. And again, there is also a description by Kang et al., which is a high supracondylar and low supracondylar, which is important when we try to learn about low supracondylar, because these are the fractures which are very near the joint, and these are difficult to reduce and also causes a lot of elbow stiffness and even avascular necrosis in few cases. Then Bach et al. Has described this. This is mostly each classification is an anatomical classification here. So it describes the fracture pattern. But this Bach et al. Has a new description where it also describes where the fracture line enters and exits. So it describes into the regular transverse fracture, a high transverse, medial oblique, and lateral oblique, both in coronal and sagittal plane. So these fractures, the pattern of fracture will also matter, because that will even dictate your, the direction of displacement, as well as where you need to put the pins around. So generally the fracture management will be based on which side the intact periosteum is. And usually in extension, the posterior periosteum is intact and the anterior is torn, whereas in flexion, the anterior would be intact and the posterior will be torn. In multidirectional, anterior and posterior, all the periosteum will be torn, which makes it difficult to manage. So fracture pattern and even stability of the fracture and distal hand perfusion will all decide how fast you take to OT and what you do and how you fix them. So clinical assessment, always see the swelling, whether it's a very gross swelling or a little bit less swelling is there, because that will also help in the management. Look for open wounds, because that makes it an emergency case and you need to treat them with open reduction. And then perfusion of the limb, which is assessed in the form of pulses, and then you note the color of the hand, the warmth in the hand, and then capillary refill. And then you put the pulse oximeter and check what's the saturation with the waveform also. And you do a quick neurological examination. The three things you ask them to do, what we call as rock, paper, scissors. Ask them to make a fist, and then ask them to show a good 5, and ask them to quickly cut like scissors, and maybe a thumbs up. So all these can assess different nerves. So cutting like scissors can assess ulnar nerve easily. And then when they make a fist, it assesses both the anterior interosseous as well as the ulnar. And if they are able to extend the fingers, it also assesses the radial nerve. And thumbs up again, classically you see in anterior interosseous nerve, where you see a pointing index. So this child, we are assessing all the three signs here. And this is the affected side, where you can see the anterior interosseous nerve palsy, the left side. Child is not able to flex the index. It's a pointing index sign. And investigation, always we get X-rays in WhatsApp nowadays. This is the X-rays are what we do. They always ask from the ER. So never accept suboptimal, X-rays. Always get two good orthogonal views, because a fracture which you think might be stable and undisplaced might be actually displaced. And it is difficult to get it in the ER, because most of the times the child is in pain. Sometimes they may not cooperate, but it would help if you are there see that you only go personally and take these X-rays, so that we can make a call and tell the parents, okay, this is the treatment which needs to be done. So in X-rays, if we see the anterior view, in the coronal view, we see the fracture line, the pattern of the fracture, whether it's oblique or transverse fracture, how much displacement is there, which is the direction of displacement. And in the lateral view, as seen in this X-ray, you can see the fat pad sign. There is both anterior and posterior fat pad sign, which is also called as a Sale sign. And if you draw a line, the anterior humeral line, it should cut through the middle third of the capitulum. In younger children, it may be it may cheat you, because there can be an eccentric ossification of the capitulum. But I think anybody more than 4 years, this is very predictable. And you also see the Bowman angle, which is about 64 to 81 degrees. So any increase in Bowman angle, you can be assured that this is a case where the elbow is going for cubitus varus. So Bowman angle is nothing but in the coronal plane, if you draw a straight axis from the shaft of the humerus and a tangent along the capitular epiphysis, they both form an angle. So supracondylar fractures, we know that they always heal. So why do we need to treat them or operate them? So that is mainly because we want to prevent the deformity. We want to maintain a decent elbow ROM, and basically most important is to prevent vascular compromise when there is a pulseless hand. So this is a case of child where they came later, neglected trauma, and the child has elbow stiffness and deformity. So this is not acceptable to most of us, even as parents. And we'll talk about treatment. And before we go here, I would like to mention whenever there is a posteromedial and lateral displacement, both two direction of displacement. In posteromedial, radial nerve is commonly involved, and whereas in posterolateral, anterior interosseous nerve is involved. In flexion type of fractures, ulnar nerve is the one which is commonly involved. So this is an example of extension type 1A, which is rotationally stable, undisplaced fracture, and it has healed in 3 weeks. If you see the anterior humeral line, it is cutting in the middle third of the capitulum here. So this is the description, and it can be treated conservatively in about 80 to 90 degree of flexion. You can give a slab or cast for the child, and no need to monitor them weekly. So this is an example of 1B, where there is a varus collapse in the medial side. Sometimes it is because of comminution, sometimes it is because of the green stick itself. So these fractures are prone for cubitus varus. So literature has recommended operative treatment to reduce the incidence of cubitus varus here. So this is a type 2A fracture, where we see that the anterior humeral line is cutting not middle third but little bit anterior to the capitulum. And in this also there can be grades where the posterior cortex is intact, whereas only the anterior cortex is broken. So these fractures, I usually monitor them every week and see. But basically try to see in good AP and lateral view whether there is a rotational instability here. And you can treat them in cast. And after 3 weeks, the cast can be out. Sometimes you get a type 2A where you think it is stable, but you see here posterior comminution is there in the first X-ray, and anterior cortex is broken. So these are, they can become unstable. So you have to monitor them. And when there is a gross swelling in the arm like this, you can't position the elbow in the, if you want to actually reduce them, you need this much of flexion. So it's almost more than 120, where there is always chance of further compromise of the vascularity. So this could be a good case for, pinning, so that there is no vascular compromise, and you can maintain the elbow in good amount of extension in such cases. So beware where there is comminution, especially posterior, where there is gross swelling. These could be indications for pinning in even stable fractures. But you do follow them if you think that there is no much swelling. You follow them weekly and see if they can displace. So this is the same example with the less swelling, but they can get displaced in about 20% of cases, and just monitor them weekly and don't send them for 3 weeks later. This is a child with type 2B, where there is a rotational instability. You can see the proximal and distal fragment, and see that they are not well aligned. There is a rotational element here. So these definitely need reduction, because most common complication in the supracondylar fracture is elbow stiffness and cubitus varus. So varus doesn't only result from tilting; it can also result from internal rotation of the distal fragment. So that's why this needs to be treated and fixed in an anatomical position. So in supracondylar fracture, when it comes to treatment, there can be three scenarios where there is pulse is very good and there is no pulse, but hand is pink and well perfused, and when there is pale white hand. So the emergency of the treatment, most of the type 1 and 2 will not have these complications, but 3 can have. So I want to just put a word here where the pulse is good, the treatment is routine. When the pulse is pale white, it's urgent, reduction, not exploration, actually reduction of the fracture. And then you see whether the hand becomes perfused or pink. And the scenario where there is no pulse, but the hand is perfused, we'll discuss in coming slides. So this is the one which creates dilemma. And even the type 2s, which I have described in very brief. So this is extension type 3 fracture. If you see, there is a pucker sign anteriorly. This is because of the anterior fragment going into the brachialis and anterior muscle, and which also sometimes hinder the reduction. So this is a type 3, which is totally displaced. No neurovascular deficits were there in this case. So this was reduced. And we'll see in the video how to reduce this fracture, how to, reduce the pucker sign and get a reduction. So I think this is a video which is supposed to play, but it's directly going to the last. So anyway, I'll again describe it later on. So, okay. So inserting the K-wires, where to insert from? Don't insert the K-wires haphazard wherever we like. So there is a, way to put the wires properly. And that also I'll talk about in the coming slide. So minimum 2 appropriate size K-wires should be there, and which hold both the cortex, the near one and the far one. So you have to be sure that you are purchasing both the cortex. And if you divide the distal humerus roughly into 3 columns, at least 2 columns it should purchase. That's the central third, lateral third, and medial third, and spread or diverse the wire so that they are not acting like a single wire and creating a rotatory instability. And what size of wire to be used, I'll describe in a coming slide. So usually in classical procondylar, there are 2 techniques which are described. Divergent 2 wires, which is done in this case, and 2 parallel wires, which is done in this case after reduction. So in addition, you can add it if you find that there is fracture instability, you can add an extra pin there. And don't follow blindly 2 lateral pins is safe and let's do that, because sometimes you get an oblique pattern. This is the medial oblique pattern where only 1 pin will be in your distal fragment, which doesn't hold the proximal fragment at all. So that be careful about that. So that's why the fracture pattern is also important, where you need medial pinning. So pin size, there is something mentioned as a pin cortical ratio. So they say that for more good stability, the pins should match the proximal cortical diaphysis of the humerus in the shaft level. So that leads to less displacement and wire bending. So when do we need a medial pin? When the fracture line is, when there is a medial comminution, when there is a high supracondylar, when there is a lateral comminution, and when there is a varus collapse. These are the commonest indication for a medial pin. And this is an example of how a medial oblique pin, if you put 2 pins, one would miss the proximal fragment entirely. That's why cross pinning is recommended. So when you're doing the medial pinning, some rules must be followed. One is to pin them in extension. Push the ulnar nerve posteriorly manually. If you're not able to do that, you can put a stab incision and then make sure that you're directly on the bone and do it. And use a low spin, like a ream mode or oscillating mode rather than a full drill mode when you're entering. And I generally use a smaller size pin if there is not much comminution while putting this. So whenever there is an absent pulse, there is a need for urgent close reduction and pinning. If the hand is well perfused, no need to do the surgery in the middle of the night. You can take it in the morning, but you continue to observe for signs of ischemia in such cases. But when there's sorry, who's there? Can you mute it? Can you mute the other speakers, please? So when there is a absent pulse with a pale hand, that's a very urgent situation. You need to inform the vascular surgeon, have them as a backup, inform that you are taking the child to theater and keep the child in NBM accordingly. Avoid regional blocks. Once you do the regional block, it all masks the signs of ischemia in these cases. So just a short GA should be enough. Reduce, and then if the pulse returns, don't send them home. Observe them for 24 to 48 hours. And you always look out for these three signs rather than the 5 Ps, which I'll talk later. So if this is a broad outline how to manage the pink pulseless hand. So emergent or urgent close reduction or open reduction. If the pulse returns, observe for 24 to 48 hours. If it doesn't return, then again you watch out, see the perfusion of the hand, see for capillary refill, warmth of the hand, and SpO2 meter. If there is good waveform, saturation is good, and you think the hand is pulsed, no signs of ischemia, you continue to wait and watch. Anywhere you see that there is signs of ischemia, I think that's an indication for again exploration. So this is a type 3 pale white hand. Don't wait for next day surgeries. Inform the vascular surgeon, prepare for emergency reduction. Pulse will return in most of the cases. When it doesn't return, then you explore in the same sitting. And post surgery, sometimes, after reduction, you get a pale white hand. Then you definitely suspect, especially when you have a fracture gap, that something could be there in the fracture site. And you explore such cases, and exploration is usually done for the vessels from anterior cuboidal fossa, a lazy S-shape incision. And this is a case where, there was a fracture gap and hand was not well perfused. So this was explored, and this also had a neurological deficit. So remember, anatomically, we know that these vessels and neurovascular, both the bundles are very close relation there. So it is likely that when the nerve is involved, the vascular injury chances and the incarceration into the fracture site or the tethering would be very high in such cases, as shown by the paper from Mangat et al. So this is a pulseless hand, well perfused. So no need to be scared, reduce them. And most of the times the pulse returns. Otherwise, maintain the perfusion, see whether the perfusion is good. And don't discharge as daycare when these pulseless hands, because you monitor them for 24 to 48 hours and you tell them what signs to look for. And don't look for the 5 Ps, which are very late signs. In children, there are 3 As: anxiety, increasing apprehension, and increased need of analgesia. So these 3 signs are reliable. Rare cases where you need to open the fractures, the indications would be failed close reduction, where you're not able to get a acceptable reduction, where the fracture is open, where there is a persistent fracture gap with the deficit, and when the hand is poorly perfused despite your reduction. So this child is having a fracture where full close reduction maneuvers failed, and had to open this fracture. And if you see, the fracture is displaced posterolaterally, and the medial spike from the proximal fragment is actually was protruding medially. You can see the ecchymosis there, and that's the side where the periosteum is generally torn, where the ecchymosis is there. And this, I preferred a medial approach there, identified the ulnar nerve and then reduced it and pinned it. This. And atypical fractures, there is a fracture which is mentioned as a reverse oblique fracture. All the atypical fractures basically means that they are either difficult to, reduce, or, the routine pinning won't work in such cases. And this is a reverse oblique. Normally, we get a sagittal pattern from proximal posterior to anterior distal, but this is reverse oblique fracture. So the way to reduce is either you can use this joystick method, what we describe as a Campanji technique, or you can also bring the distal fragment anterior, slide it anterior to the proximal, and then do the pinning if it is possible. And then these are the atypical fracture: flexion type, comminuted type, oblique fractures, where there is type 4 multidirectional instability, intra-articular extension, and a few segmental fractures where you have a shaft and a supracondylar fracture. So this is a flexion type fracture routine maneuver of, the probably if there is time, I'll just show the video in coming slides. So quickly, this fracture was reduced through open reduction because no matter what I did, I couldn't reduce it. But there have been description of how to reduce this flexion type fracture. One is push pull technique, the AO technique, and joystick. Push pull is nothing. You keep a folded towel at the acting as a fulcrum at the fracture site. You give traction and push the distal fragment to align with the proximal, and then you pin it. And AO has described the same technique where you do the fracture in extension and then push the distal fragment, reduce it, extend, and then keep holding the thumb there, and then you put the pins. And this is a fracture. There is malrotation, ulnar nerve palsy, and this underwent, exploration, open exploration, and reduction with pin fixation. So this is example of lateral oblique fracture with the flexion type. So this is also again was very difficult for me to reduce. So I have used a transolecranon pin here in this case and maneuvered the distal fragment into valgus and tried to pin them to closed means. That's one more technique. And when there is multidirectional instability, you might use a olecranon pin or a Schanz pin proximally, whichever helps to get the reduction. Basically, both the periosteum is torn here. And you get comminuted fractures, and this is a case I had done almost 10 years back. I Now, if you see what I did to make, I suspected there is an intra-articular component. So I had put these pins to reduce it and then aligned it with proximal fragment. But, during push and pull, you can still get displaced. And this is the end result. There was light avian of the distal, trochlea and leading to cubitus varus in this case. But that's one more. And this is an example of floating elbow injury where you have a proximal shaft, distal, both bones, forearm, and supracondylar fracture, which was, managed. First, the shaft fracture was fixed, and then the typical maneuver for reduction was done. Fractures was fixed, and distally we put this. So these cases, when managed in just cast, leads to displacement and can also have compartment syndrome. So you have to be careful managing floating elbows. You need to fix them and watch for ischemia. And this also child underwent exploration because the pulse, we felt that it was not adequate in the post-op period and that a surgeon had done a bypass grafting in this case. Thank you. And if quickly time permits, can I show the video if possible?
Sure. Yes, sir, you can.
Oh, sir.
I think the video was working with me, but in this talk, it's somehow not working. Just give me some time here.
Till then, if there is any question.
So in the video, actually, I'll describe the maneuver so that, we can know what's the actual maneuver, because that's the most important thing and most of us would feel that this is required.
So, Vidya, did you talk about after fixing the supracondylar, you should check the rotational
Yeah,
stability?
so it's there in the video, sir. Let me just quickly.
I missed that. I missed that part. If you're not, I will ask you to play it again because we see lots of patients, primarily treated by our colleagues, general orthopedic colleagues,
Yes.
and after putting two wires, they check the lateral view either in the cross table fashion
Yeah.
or when the arm is in external rotation. But friends, remember when we are immobilizing children, we are putting the arm in internal rotation. So the rotational stability should be checked in internal rotation either in this way. And if you find a rotational element, then it's an indication to add a third wire, uh, maybe a
So
medial wire. So Vidya,
shall I play
please,
the video?
yeah, please guide.
So this initially traction and counter traction is given, and you try to correct the coronal plane deformity by putting your thumb and correct it. Then flex the elbow, give the pressure over the olecranon, and once it is fully flexed, check the Jones view to see that AP reduction is good. And now this is what we are talking about, what Molin sir was talking. When we external rotate, if it is unstable, you can see that there is displacement. So in this case, either you can move the C arm. This is the AP view which it will show. You can see that the C arm should move into lateral view, and then I tape it generally there, and in the same position I do a semi-serial technique where I paint and drape and put a whole towel there. And when there is a posterior medial displacement, you always pronate the forearm and fully flex it. When there is a posterior lateral displacement, you supinate and flex it so that the reduction happens and the fracture gap is reduced. And now when you're sure AP lateral looks good, now you start with your two lateral pins and feel and go. That's the most important thing. That's how you get the purchase. And this is the first pin which I'm putting, and then followed by the second pin. And if required a medial pin, whenever required, I always remove that the plaster and put it in extension and then pin it. And this is 3 pin because once I do the reduction, I always keep the elbow. This is the pucker sign which we are seeing. And it can be reduced through milking technique, where we try to milk out the brachialis muscle from that proximal fragment, and you hear a pop and you see that the elbow you can suddenly flex well and there is no more tethering of the skin. So, and then we give a slab. No need to give in 90-degree extension. Once it is fixed, you can give in a liberal more about 60-70 degree of flexion also. And I have not used cast. Mostly I use slab because post-op edema will be there. And if there was a pink pulseless hand already, I observe them and monitor them for 48 hours.
Yeah, so one more thing which I would like to add, again, you checked it like this. It's easy to externally rotate,
Yes.
but always also try to internally rotate and see, because in that position, we are going to immobilize the child, right? We are putting that in sling, and there you have to make sure that there is not much rotation. Another word is we see lots of what do you say? It's a medial impact or a comminution, type 2 supracondylar. I hope you talked about that also.
Yes, type 2 was covered.
Yeah,
Type
so
even type 1B.
yeah, so there we now fix them when we see a comminution or a varus impact fracture, because those are the fractures who can end up into cubitus varus if we don't treat them well without thinning. They may collapse into varus, so you should fix them. Great. Any other question or comments, Gaurav?
Dr. Molin, I want to ask one or two questions.
Yes, sir,
Hello.
please. Yeah,
After pinning, what position you keep in supination or pronation? And secondly, if you have passed the pin more inside, should you take it out or you should not? Because sometimes pin becomes loose.
yeah. So Vidyasagar will tell Vidya, what is
So
the
the first
position of
question,
immobilization?
the position of immobilization, I just maintain them in whatever comfortable position. Usually it is in slight supination. Only for reduction, you use the, maneuvers of supination or pronation. In posterior-medial displacement, you always, pronate, and in posterior-lateral, the easy way to remember is move the thumb towards the direction of the displacement so that the fracture gap is reduced. After reduction, putting the pin, it doesn't matter how you immobilize. Whatever comfortable position, it is okay. And the second question, the pins, if they are long enough, no, especially if you are putting from lateral side, it can poke the medial structures. So it should be just enough so that it is just outside the cortex. And if you feel that it is longer, you can always retract a little bit, take it back, and then leave it there.
It can become
Yeah,
a loose also if you remove the
Yeah,
pin.
if you do that multiple drilling and all, that's why you have to be, not do it multiple times. And as you do it, you get the knack and get the feel of how you can get through a single,
yeah.
drilling the other cortex.
And
The
the thickness of
yeah,
the pin I wanted to know.
So I have already mentioned in this. So two small pins also leads to instability. So there is something called as a pin cortical ratio, where you compare the pin diameter to the humerus shaft cortical diameter, not the whole cortex, but a one side cortex diameter. So it should not be less than zero point 0.9, they say. So it should be nearing that cortex diameter for optimal stability.
So one thing about pronation or supination, after doing a typical maneuver of reduction, you check the ulnohumeral view. If it is open or there is some gap on the lateral pillar, then you pronate and then it will close. If there is no gap on the lateral pillar, then you keep it supinated. So that is the simple thing we follow. And yes, so as the diameters are 1.5 in younger kids and 1.8 sometimes 2 millimeter in older kids more than 6 years. But you don't adding multiple wires will not improve the stability. The configuration of wire which Vidyasagar has said, uh, the first wire should go from the inner half of capitellum, and that should be the four cortices wire, as we have rightly mentioned. That you feel four cortex. As in general orthopedic surgeon, I remember when a wire is going through the medial part of capitellum, I've always thought this is going through olecranon fossa, and so it will restrict the motion. But no, it is going through the cortical part, and it will not hamper your range of motion. So don't worry. But start your first wire. You divide the capitellum into medial half and the lateral half, and your first wire should be going through the medial half, fixing the medial pillar, and second wire should be coming outside the capitellum, fixing the lateral pillar. And there's those two wires, if they are divergent, they are enough. We don't need to make the child Vishnu Pitama by putting multiple wires, right?
Yes, Maulin, I have two comments.
Yeah,
Number one is that fundamentally we think that we have hold of the proximal fragment manually. It doesn't happen because there is a edema. You think that you have catch hold of the proximal humerus so well that you are able to reduce. So all those cases where you are not able to reduce, put a pin on the supra part of the supracondylar area so that you can have a hold. And you will see those who are, you think you will have to go with open reduction, you might be able to do close reduction because now you have a real hold with a very small like 3 mm pin on the superior part. And I know that because I had given a gold medal to that paper in one of the IOCONs. And
yeah,
secondly, regarding this two pin, thinner the pin, more is the minimizing the injury to the epiphysis. That we know. Thicker the pin will give more epiphyseal problem. But thin pin also will work with two ways. One is that you pass, as you said very correctly, in a different direction. But if you fix them outside with a alpha or beta clamp, it makes a world of difference of stability. Big difference. And unfortunately, still, orthopedic literature has not come out with what happens when you fix both the pins externally with alpha beta clamp. What is biomechanical changes which increases the stability is not learned very well. But it is very obvious that those pins, particularly when they get little bit of pin tract in the course of time, that also will be minimized if it is fixed externally with the two alpha or beta clamp. So that is what
yeah.
is my experience.
So this has been tried, and there are studies by fixing the wires outside the skin, and we have found experimentally there is no uh, excess of stability which is required to fix these fractures. There are studies of 500 supracondylars where they have just placed two pins. They compared with the lateral or cross pins, and they have checked with the by putting some external fixator device to make it more stable. But two pins of optimum diameter placed in the divergent manner, they provide enough stability because the common age for this fracture is between 5 and 7 years, and you need to immobilize them only for 3 weeks. So we seldom see pin track infection. Even if there are papers now that you use a semi-sterile technique, then also results are fine. And just supracondylar fractures, I must say, with experience, you would know which are going to be uh, multidirectionally unstable fractures. Those are the one who are unstable in front and back. Those who have huge edema. And there, sometimes, as you said, we use the proximal pin to fix and kind of derotate the proximal fragment. But I would say that about 90% times we are okay with this reduction maneuver and two lateral pins. And there are atypical situations which would happen at around 10% time where you have to milk the brachialis or you need to add. And and worst scenario is even by putting a proximal wire, you are not able to control. You have to put a transolecranon wire, a temporary transolecranon wire to stabilize. So we are going to talk about these atypical situations next week. But yeah, because the extreme stability is not needed in nicely fixed wires, we don't use uh, external device to provide added stability. Great. Any further question? If not, I would invite Preksha to uh, share her presentation. And Vidya, this is an interesting fracture morphology. So have a look and then we'll discuss. Yeah, Preksha, you want to share your screen?
Yes, sir. Is it visible, sir?
Is this the first slide? These two papers or
1 second, sir.
yeah.
Good morning, everybody. I'm Preksha, and I'll be talking about a few interesting cases which we came across in our recent practice. So it's mostly lateral oblique medial low supracondylar humerus fracture. This is a rare fracture pattern. So these are the papers we came across. So Dr. P.N. Gupta describes two cases which was conventionally treated as supracondylar fracture and lateral condyle fracture, which later had deformities, and then they came up with these fracture patterns. So for us, the first case which we are going to discuss is a 11-year-old male child. This was the first x-ray and conventionally treated. So on the first in the first presentation, you can notice the double fossa sign on the AP view, and this is the x-ray which is noticed after 2 months. Since he was
Okay, so Preksha, can you yeah, so now this was a very unusual fracture pattern. On AP view, you can see the double fossa sign, you see two olecranon fossa, and when you take a lateral view, you feel that this lateral condyle segment is continuing with the radial head, but the rest of the humerus has gone in front. If you try and put a complete pure lateral view, you can see the sagittal fracture pattern, which is if you see the figure of 8, it is passing not through the center, but it is going below this. So there's a very low sort of fracture. And so the question is it a lateral condyle fracture or is a low supracondylar fracture? Is it an elbow dislocation? What it is? So, Vidya, what is your take on this?
I think that medial epicondyle and the proximal fragment are carried anteriorly.
Hmm.
The, the lateral part mostly is with the ulna and the radius. I can't actually make out trochlea here, but if the
Hmm.
trochlea is with the distal fragment, then I would not put it as a lateral condyle fracture. No.
Right. So, any other comment, Gaurav? So this
Sir,
is not a
on the
typical. pattern, we see with any low supracondylar or.
Sir, I feel on the lateral view, it is quite clear that it is more of a supracondylar because it is carrying the distal part of the humerus as well. And I'll classify it into a low supracondylar.
Hmm. Yeah. So low supracondylars, usually they have the fracture line goes little above the capitulum, while here the whole chunk of lateral part is there. So it's not low at the on the lateral side at least, and we don't know anything about medial side because it's cartilaginous, right? So it's difficult to define on X-ray. And any other comment from delegates about the fracture pattern? Yeah. So when you see this, unfortunately, this was treated as a lateral condyle fracture by an orthopedic colleague, and I saw a big lateral incision, and then probably they passed a couple of pins and they removed it at 3 weeks or 4 weeks, and the bone was not in position. So the child presented to us at 2 months, and so we wanted to study this pattern more. So we got a CT scan. Preksha, do we have CTs?
Not on this, sir.
Okay. So,
So these
but I
last
would,
two X-rays, are they post-surgery X-rays? The right-hand side, like.
yeah,
Yes, sir.
Okay.
yeah. So they all are actually, yeah, post-surgery X-ray, and there was no union. Patient had pain, limited motion, and you can see the distal fragment has moved fairly anterior, around uh, the coronoid. It's beyond coronoid process.
Yeah, it's
So,
possible.
so two things were here. One thing is to understand the fracture pattern, and second is to now how to approach it. So, we got a CT scan and we got a fair idea that where the fracture line is going. And I mean, it didn't help much in terms of more than X-ray. It's now evident on X-ray what's going on. So, what approach and how would you treat it, or you would leave it, Vidya? Would it remodel? The child is only jog of movement. How would you manage it now?
So I don't think this will remodel, in my opinion, because the
Hmm.
displacement is also more. And medially, I'm not able to make out where's the extent of this thing. But definitely, the proximal fragment is carrying most of the medial
Hmm.
model and stuff. So, because the medial side periostem is likely to be torn, and I think there is approach laterally also, probably open reduction was done. So I would
Yeah.
actually approach this via a medial approach first and see what's happening, untether their things, see if we can reposition. If it's not
Hmm.
coming to place, then I would not hesitate to do the same lateral opening, medial and lateral, and then get it in position. And if it
Yeah.
might be difficult at 2 months, but
Hmm. Hmm. Hmm.
triceps and all could be contracted in these cases.
Yeah, that's right. So Sujit said that oblique shear fracture exiting medial to trochlea. Yeah, so we had an opportunity to see this fracture, and that's why I took posterior approach. I wanted to see the exact fracture configuration, and then I can do adjustment both on medial as well as lateral side. Uh, yeah, so let's stop. So these are the intraoperative images. Uh, Unfortunately, there are a few images are skipping, but this is a tricep tongue approach probably, or I mean, olecranon osteotomy approach I had taken. And you see the fracture line going medial to the trochlea. So it is not pure intra-articular. Sujit said that is medial as an oblique fracture exiting medial to the trochlea. So there was no intra-articular fracture, but the fracture line was going way down medial to the trochlea. And after removing the fibrosis and adhesion, I could lever that fragment back, and then we fixed it. with a combination of screws and wires. Why I opened from the posterior approach? Because I wanted to fix that small medial piece, and so I think we fixed it with a screw from the medial side, Vidya.
So what was the status of ulnar nerve here? Was it okay before pre-op?
Yeah. It was okay. We dissected and freed it. You can see on this. It was a quite extensive dissection, but ultimately anatomically we could place it. Initially, we fixed it with wires, and then we added screws to compress the fracture fragments. Yeah, in this boy had a fair range of motion. Yeah, Preksha, you can go ahead. He had terminal, I would say terminal 20-25 degrees of restriction of flexion. Why should we tell you? Oh, it's 9 o'clock. So yeah. So now based on that experience, we came across a few more fracture patterns in acute settings. So Preksha, you want to take us through?
Yes, sir.
Maulin,
Yes,
Maulin,
Mukund. Ha, sir.
Maulin, I just wanted to ask you did the olecranon osteotomy at 11 years old child?
Yeah.
Is-
So there are papers now, sir. Olecranon osteotomy in adolescents will not have growth abnormality.
Up to
So there are
what age?
papers.
Up to what age you can do that?
Yeah, we can do up about 10 years. We can do. If the fracture
Okay.
pattern warrants it, we can do. Of course, there are now this patient was operated by me before 10 years, but now there are many approach, a collateral approach and triceps sparing. So we can now avoid olecranon osteotomy. But at that time, those were not popular. But there are papers for intraarticular, a T fracture. We can do olecranon osteotomy and in adolescents without any growth disturbance.
Thank you. Yeah.
Yeah. So now, Vidyasagar, if this fracture pattern comes, the lateral condyle part is with the radial head and the rest of the humerus has moved forward. So we could correlate it with the previous injury and we realized that this is not a lateral condyle. It's a supracondylar, which is an oblique pattern. So we term it as a lateral oblique and low medial. So it is starting from the lateral pillar, coming down, and on the medial side, it exits medial to the trochlea. So it is neither a pure low supracondylar, neither a lateral condyle. So and then we do routine maneuver, we do for supracondylar, and this is how we fixed it. And if
Can I say
Jawahar by yeah, yeah,
for the benefit of delegates, if you see the first X-ray, the pre-op, it is easy to see the lateral view and confuse it with a lateral condyle fracture. But the key here is, if you see the AP view, the humerus, distal humerus, the radius, and the ulna, all three as a unit have moved
up.
posterior-medially. So when this
Mm,
happens, you should suspect that it's not isolated lateral condyle fracture.
exactly. Yeah, and then once you identify this fracture, but it's not difficult to fix it. It's a simple supracondylar kind of thing. And if they are once you reduce it in acute, they are not very unstable as well. So yeah,
So, sir, did you
yeah,
just do a close reduction? Was the maneuver difficult or you use a
no,
different
no, no,
maneuver?
no. It's the same. It's the same maneuver, and reduction is not difficult. The only thing is if you think there's a lateral condyle, and now in the era of song classification, you would think that this is completely toppled off or separated. You fix it, so you don't think this is a lateral. It's a supracondylar type injury. That's the message. Yeah, and then one more case we came across is a bit older child, 10 years old. See
So,
again this fracture pattern, yeah. Preksha, you want to explain?
similar as seen in the previous case, it was a similar fracture pattern. You can see the proximal fragment like moving more anteriorly and the distal fragment staying back in its place.
So the same, yeah.
So this was also reduced like a supracondylar fracture, and pinning was done. Conventional close reduction and K-wire pinning was done.
Yeah. So historically, we reviewed the literature and we found Dr. P. N. Gupta, and there are few more papers. They placed it as a dilemma of the fracture pattern. What pattern is this? Is it a lateral condyle? Is it a supracondyle? But now, because we have to identify an opportunity in adversity. So as we required open reduction, we could now understand the exact pattern of fracture in this sort of injuries. And this was presented in Pause as a poster, but I think we must write this up. And I would invite, if any of you have similar pattern, then we can make a bigger series, Yeah, Vidya?
Hi, sure. Now after seeing this, I think I have to look the records now. Something might be there.
Yeah,
Yeah.
because unless we explain or we describe, it will either go as a lateral condyle or will go as a low supracondylar, but there's a different and atypical fracture. So I think we are coming to conclusion. Gaurav, we have to conclude. Thanks, Preksha. Any other slide? I'm sorry.
No, sir. These were the 3 cases which we came across.
Uh, Now, Preksha and Kunal, few things you need to do is you have to share the basic important papers published in last few years. You have to share that paper, which are the wire configuration which are leading to failures. That's a very good paper from Jack Flynn. And
Yes.
then we should share on our fellows group.
Okay, sir.
Yeah, Gaurav, you can conclude. Thank you very,
Yeah,
very much,
so,
everyone.
so thank you, Vidyasagar sir, for this such a elaborate talk where you have touched almost everything in supracondylar. And thank you, Molin sir and Preksha, for giving this insight on this atypical and different kind of fracture series of this low oblique uh, supracondylar exiting medially, more like looking more like lateral condyle. So it is, I think it would be worth to write this paper because not many of us would be knowing, at least I was not aware of this thing. So I learned about this. Thank you very much. And I hope in the next webinar, we would be coming with atypical supracondylus where we would be seeing more of these complex fracture patterns and we'll be learning the knacks of treating them closed. So thank you everyone for joining us and
Have a
wait
good
for
day.
announcement for our next webinar.
Thank you, Dr. Molin.
Thank
Thank
you.
you, Gaurav. Thanks, Vidyasagar. Yeah, take care.